Welcome to Healthcare by the Numbers, a podcast that uncovers what's driving healthcare transformation. Join us each episode as Caravan Health leaders interview the brightest minds inspiring healthcare innovation and discuss the numbers which have shaped their thinking.
Welcome, everyone. I'm your host, Louise Yinug, Senior Policy Analyst at Caravan Health, and this is Healthcare by the Numbers, a podcast that explores the numbers driving change throughout our industry. To learn more about Caravan Health, this podcast, and to check out episodes of the show, visit caravanhealth.com. And be sure to sign up for our newsletter to be notified of future episodes. You can also visit our program page on Healthcare Now Radio and follow us on Twitter, LinkedIn, and Facebook under our username @Caravan Health. Today, I'm pleased to be talking with a Caravan Health leader about the technology powering accountable care. Tom Hawks is Caravan's Chief Information and Digital Product Officer, and we're going to get into how Caravan's approach to technology drives value-based care for our clients. Welcome, Tom.
Hi, Louise. Thanks for having me today.
We're so happy to have you. At Caravan Health, we guide our partners in their journey transitioning to value-based care. That includes the technology backbone that makes value-based care possible. Tom and his team are leading the technology side of the business. Tom, can you share your background and what you do at Caravan Health?
Sure, Louise. So I've been in really data and analytics for 25 some years, and I've been with Caravan the last 5. The first 10 years of my career, I did a lot of large Fortune 50 consulting for folks like McKesson, Wells Fargo, Comcast. And what I found in that work, while I got in some really interesting technology projects, I found myself a little hollowed out. I didn't find kind of the call to mission that really would make me feel fulfilled. And especially as I was having kids almost 20 years ago now, I started to appreciate and make sure I wanted to contribute to the greater good. My wife had actually already gone through nursing school. She was working with Kaiser Permanente at the time. And so about 15 years ago, she drew me over into healthcare and convinced me to consider moving to Kaiser Permanente, a large national health maintenance organization or an HMO. I spent about a decade with Kaiser at the enterprise IT level, both on the hospital and health plan side. And then the last 5 years, also with one of their medical groups, I got the privilege of moving out to Hawaii, which was one of the most awesome transitions one could imagine. I worked a lot on pop health automation and ambulatory systems. And I think most folks know Kaiser is generally regarded as one of the pop health leaders up there with Mayo and Intermountain and Geisinger and systems that really drive pop health all the way out to the endpoint of taking care of patients to the best way possible, out in the home, out in the ambulatory clinics, and not in the ED and the inpatient realm, which is a great experience for me. I did a lot of pop health tools that we integrated into Epic, where we actually absolute automated things like mammography scheduling for women. We did IFOBT kits for colorectal cancer screening that we could send home and receive back to the lab. And we were able to get the Kaiser Hawaii health plan up to a 5-star rating so that they were able to get year-round enrollment within about 2 years of a lot of automation. It went from 3 stars to 5 stars. I also spent some time with another health system. I was a director on a health information exchange of Hawaii, helping to collaborate with how we exchange data between payers, providers, hospitals, et cetera. And then I was looking at Caravan actually as an opportunity to help me with a clinically integrated network that I was managing out in Hawaii. And that's when I met our founder, Lynn Barr. And while I was looking at Caravan as a vendor, in the middle of that, my wife and I decided to consider move back to California. We had 3 daughters who were coming of high school age. We wanted to get them good opportunities towards university options. So we decided to move back to California after a 5-year stint out on Oahu. In that transition, Lynn kind of turned the table on me and said, "Hey, Tom, I'm really interested in getting Caravan into some more technology. Would you consider coming to work with me at Caravan?" And that was about 5 years ago when I started. We've been making up fun things ever since. And then what do I do at Caravan? So Caravan, as you noted, I'm now the Chief Information Officer, so I oversee most of our internal IT operations, our support desk, and some of our data infrastructure and engineering work as well. I'm also our Digital Product Officer, so the product teams roll up to me in terms of how we try to craft and curate a roadmap to bring good tools to market to help our clients succeed in value-based payment systems and deliver population health.
I think it's so fun to hear about people's backgrounds when I do these podcasts. I feel like Caravan employees come from absolutely all over, and you never find out those fascinating little details until you really sit down. So thank you for sharing.
Surely.
So Tom, we do like to spotlight and frame our conversation with numbers that give a sense of the scope and variety of the technology challenges facing Caravan. So just to give sort of a picture, Caravan clients are responsible for over 500,000 attributed Medicare lives. In fact, in 2022, I think it's closer to 600,000, and nearly 1 million assignable Medicare lives. Patients of Caravan clients have over 1 billion Medicare claims across parts A, B, and D in our claims warehouse. And then from the specific technology standpoint, in 3 years by 2025, all shared savings program ACOs, including, of course, Caravans, will move to a new electronic reporting system for the quality measures that are required to show success and earn shared savings. So those are the numbers. Tom, you're doing the hands-on work every day of guiding our providers through the systems that make accountable care and population health work. What numbers stand out to you?
So, one of the things that I've found with Caravan over the years has been, our impressive increase in scale over time. And what that has meant to us on the technology side has been a very large volume of data. As you noted, with over 1 billion claims, that represents 4 terabytes of storage in our data warehouse. That actually hits the boundaries of some of the traditional storage systems that we initially used. We use an entirely cloud-forward architecture, predominantly leveraging Microsoft Azure. We also do a little bit with Amazon Web Services, but that's allowed us to have a highly scalable architecture to support Caravan's growth and all of the activity of our clients, our providers, and their patients. We support the integration of over 43 different EHRs. That's another thing that's been a challenge for us, but also an opportunity to help as many practices and providers have access to the tools and submit the data that they need to be very vigilant on the care for their patients to support pop health. We support about 178 different communities. A community can be a health system included with multiple satellite or community practices that participate in that community. So it's a much larger volume of total brick and mortar footprints of care, because that's over 1,800 practices that we support, and that's over 24,000 providers. So getting the tooling to make sure that we can store all that data and be responsive in our applications to support them in the needs that they do, all the way down to the point of care with tools like face sheets that they might use every visit, every encounter with their patients, has been a fun challenge for us to work through and enjoy at a national scale.
So I know that a lot of our last year, and for you, certainly more than the last year, has been about the launch of Caravan Coach, our population health software platform. I'm wondering if you can tell us more about why Caravan launched Coach, and specifically if there were limitations we had identified with the previously available solutions.
Yeah, so we were on a platform for several years, and one of the challenges that we found, it was a very open analytic platform. And by open analytics, what I mean is this is a platform where our clients could explore kind of any set of hypotheses. They could look at any set of variables to explore and watch for trends and identify correlations. The problem that we found is clients ended up chasing down a lot of kind of dead ends and, lack of a better term, wasted time. So what we chose to do instead is to offer what we often call a curated analytic journey. So we've got a data and analytics team that's done a broad expanse of research across the drivers that we find are impactful, not just in total cost of care, but for the overall outcomes, including quality outcomes for our patients. And so by identifying those drivers with really deep and highly trained analytic individuals on our teams, we've been able to curate a set of reports that help our clients focus on what we used to call, the true path north of making sure they're going in the right direction, not only to take care of their patients and keep them healthy and hit those quality outcomes, but also hopefully reduce the total cost of care, which helps the overall health system.
Oh, that's so interesting. So I had been thinking in terms of limitations, but in fact, maybe there was in some ways sort of too much, as you said, open-ended options under other systems. And what clients really want is to be to have a little bit more of a targeted approach.
We found that that's definitely resonated with clients, is that they appreciate that we can show them the path and we have the data to back it up. So it's not just that we kind of propose standardized recommendations that are applicable across the board. They're truly tailored and customized to their community, and they can see the data behind those recommendations to understand why we recommended advise and how they could proceed and progress to improve.
Oh, sure. And to be able to take advantage of all of that knowledge and expertise is sort of the whole reason we're here.
That's right. And I think aside from the analytics, to note some of the other components we chose to bring into Coach that follow a similar pathway is we also did modules, our care modules, really around helping at the point of care, helping the pop health nurses particularly take care of their patients and proactively manage population health. But we also have an improve module, which is really a collection to support practice transformation. Because what we found is a lot of clients really, they want to succeed in value-based programs. They want to make that leap into how do they do proactive, efficient population health across disease states, but it's really hard to do. And so we've been able to collect a lot of those best practice guidelines, even things like the simple PDSA, like plan, do, study, act materials into that improve module to help them do that practice transformation in a structured, methodical way. And especially even for larger health systems, we're then giving them the tools that they can use to train across all of their entities to make sure they bring consistent process and hopefully effective pop health all the way out to their members and patients.
So I think I mentioned that the development of Coach, of course, was a years-long effort. I'm wondering if you can tell us what accomplishment you're most proud of in the development and rollout of Coach, and maybe what surprised you about that.
There's a couple components. So I think one of the proudest components I would reference is, Caravan made a great acquisition, I think, some years ago with a smaller entity called Wellpepper that had a patient engagement application. That really helped us bolster our software engineering team, and particularly the head of engineering, Mike Van Snellenberg, has been a great catalyzing force for us to really mature and bring forward our software engineering principles and processes. And what that's resulted in is we've actually exceeded our availability targets here in our first year. We've had over 99.9% availability throughout business time for all of 2021, which really was a great accomplishment for our first year of being a platform online. So there was the fun of integrating new resources and new teams and really building that strong engineering discipline as Caravan transitioned to being a software-enabled service company, because this was the first time we tried to offer our own robust software. And I'll frankly admit, I had a little anxiety going into the year of how successful we were going to maintain stability at the scale we needed to support these 1,800 practices and 24,000 physicians. And I've been really excited and pleased that it's worked out. So I'm proud of that. And I really thank our engineering teams and Mike in particular, who've helped us be successful there. From a surprise perspective, I'll just say that the client uptick surprised me. So we had a platform before, and we would see about 300 to 350 distinct users that would come in basically every month. So those 300 to 350 folks were coming in every month, doing a variety of activities to do whatever they need to. Analytic exploration for how many diabetic patients do I have, maybe running face sheets for the encounters when they're going to care for those patients. And we've now found on the Coach side that we get nearly 1,000 distinct users coming in every month. In some months it's over 1,000, but 1,000 is about right. So that's nearly a threefold increase in terms of the footprint of clients that we have that are coming in and intersecting with our application every week or every month, which is great. And then similarly, for when those folks were online, we used to get about 30,000 interactions by those users in our application per month. But now we see about 110 to 125,000 distinct monthly user interactions. So that's nearly a fourfold increase in terms of how much users are using the system, the things they're pulling down, whether that's across our care, track, or improve modules. So we're finding really deep usage, which again was really exciting. It's one of those, I go back to Field of Dreams, a Kevin Costner movie from probably 30 years ago now, but there's this, if you build it, it will come model. I would say from my side on the technology side, you think you're building something that can be helpful for people, but you're really excited when you actually successfully get something out and you see significant user uptake and uptick over time.
I was going to say the numbers themselves really seem to tell a story, right? That clients needed this, and once they had it in front of them, they flocked to it. They're using it at this much higher rate, many more people. Have you heard specifically from clients about their reaction? Are you hearing success stories? Are you hearing about how they're using this beyond just the numbers and the volume, and how they're using it to promote their own population health journeys?
Yeah, we've heard some really good feedback from folks. So both our practice transformation team collects feedback kind of on the fly through the roadmap calls and steering committees. And overall, I selfishly admit, owning the product team, I probably have an optimism towards this, but what we hear is a preponderance of positive feedback and appreciation for most of the tools. There's always some new areas that they're interested in us exploring, but folks have really given us high marks in terms of being able to contribute to their work in delivering pop health, both the analytics of what they see in track and what their opportunities are and where they need to focus their efforts, as well as some of the new things that we added even mid-year or later in the year, and we enhanced things like our face sheet to support at the point of care in those tools. And then for a success story, we've got several that have come through. But one example, we have a client that was, we trained really deeply to make sure they were comfortable and confident in their coach application. And they were working on the patient cohorts that they could generate, in particular for different diseases, and watching the predicted risk category that Caravan offers a proprietary risk algorithm to help them focus on the patients that we think are going to bear the most cost and therefore risk to their organization. Specifically, our high-risk patients we have found and we've categorized to be about 10% of the ACO population, but they represent 60% of the cost for the ACO. So aside from there's a great cost opportunity to make sure you're managing costs for those patients, usually those patients are sick, have got a lot of comorbidities, and getting in front of their care is a great way to influence that individual's actual personal outcomes, keep them home and safe. And there's a side benefit that hopefully we can help reduce the total cost of care for the health system as well. So in their example, they decided to work on COPD, or chronic obstructive pulmonary disorder. And when they were working through that to look for their high-risk patients, they actually were watching even for some of the low-medium folks to see who was within outreach. And when one of their nurses started to outreach for those patients, they identified somebody that actually had a CVA, or a cerebral vascular accident, and they'd been hospitalized in an outside facility. Now, the important part here is for that outside facility identification, by default, unless a health system is getting the admit, discharge, transfer, or ADT notifications, they may not realize that their patients are receiving care out of network. But because we have a comprehensive claim set offered to us by the Center for Medicare and Medicaid Services for ACO participants, we can watch for those out of network conditions as well and make sure those are presented. We offer that both in a patient timeline so that our providers at the point of care can see the timeline of history that their patients have had for what services, for what providers, and what locations when. And then also they can view this information on the face sheet if it presents new diagnoses or procedures that they didn't realize were available. And so in this case, because they had initially missed the follow-up for primary care physician, they were able to outreach and determine that this patient was struggling to track their appointments and manage their medications, and they really did need some more support. So they were able to engage in a much more proactive way and help that patient be healthy, hopefully have positive outcomes, and be able to stay home and stay out of the hospital. So that was a great example that I was pleasantly pleased to hear that came out of a kind of a blend of both of our analytic pursuit and our point of care nursing tools.
Yeah, it really takes you beyond the numbers to get into exactly how clients are using the tools to improve patient care.
Yep.
I did want to ask a little bit, because I always do, about some policy questions. I have a particular interest in this. And of course, I know everybody involved with ACOs is well aware of the quality measure overhaul that's coming in the shared savings program, and specifically the move to electronic reporting. Of course, your team is intricately involved with this. Can you tell us how Caravan is preparing for the quality measure overhaul?
Yeah, absolutely. In 2022, performance year 2022, clients will be able to electively begin to participate in the ECQM, or the Electronic Quality Measure Program. They can actually submit their data that way over ECQM and via the traditional model we've been using through, generally speaking, through the web interface. They can submit both of those measure sets, and they'll be scored based on whichever is better. So Caravan is going to work with a select set of clients that we think have strong opportunity in this area, and we're going to be working to develop the capability to help them submit ECQMs at that ACO level so that we can do some test prototyping this year, do that test submission, possibly benefit from it, but ensure that we work through and prototype through the challenges of that model and work with the clients to make sure they understand the workflows, and we can harmoniously determine this process all the way from that point of care clinician perspective through the hospital health system reporting into what Caravan's obligations are and off to CMS. So we're going to take advantage of this year where we have that as an optional pathway, and we'll be doing that to make sure we can fine tune the process. So we'll be ready for the subsequent years as it becomes mandated.
So clients are able to opt in and then have this, as you were saying, sort of best of web interface reporting or electronic reporting, which seems like if you've got the capabilities, really the best of both worlds.
Yeah, I hate to say opt-in in terms of, we're gonna probably curate those participants that we'll choose to work with that we think are most equipped, because there will be some technical obligations on their side to be able to contribute. So it will be a little bit selective in terms of how our practice transformation team will probably help us select those participants. But we'll see. We'll make it as broad as we can. And if we can, we'll make it widely available even for this year. But we're going to have to see as we work through some of those details how broadly we can scale that this year.
It's like a good way to take advantage of the delay. We've seen a couple of delays now in this overhaul, and it seems like a great way to take advantage of that extra time.
Yeah, but we're not going to sit pat, to be clear. Like I think we all see the writings on the wall. I'm actually supportive of the direction that we're headed, but we know it's coming. So we're not going to delay another year on the Caravan side of ensuring that we've got the technological capabilities to support our clients and be successful here with their quality reporting.
I am interested in hearing a little more of your editorializing about what you think of the quality overhaul. It sounds like you're in favor. It sounds like you think CMS is really headed in the right direction with this.
I do. And I freely admit I come from the technologist background with that perspective. But I've been accountable in some organizations where I did account for like our NCQA HEDIS reporting obligation, particularly for the effectiveness of care measures. I've had to report on meaningful use over the years, as well as MIPS and promoting interoperability. So I've dealt with a fair amount of large, national scale reporting obligations. And there's a huge administrative burden that I've seen on the health system side. And again, from my about 12 years on the health system side with Kaiser and Queen's Health Systems in Honolulu, the volume of staff that are required, particularly in the traditional chart review model, it's really I don't hate to say unfathomable, but I had a team at Kaiser Hawaii where I had to have 2 dedicated software engineers basically tracking the HEDIS changes, as well as a business analyst. And I had some partners on the health plan side as well that had the utilization measures. So we had to have a team of staff working on that throughout the year just to keep pace with change, et cetera. Moving to a smaller measure set and a standardized measure set that's reportable across patients and across plans, actually, I think will streamline and simplify the reporting. There has to be changes to benchmarks and scoring, because we know that this broader population will generally not score as well as the more targeted population that we've seen historically. But I think the opportunity to simplify the administrative burden and reduce that cost and labor required for annual reporting will definitely be a benefit overall for health systems and the health system in general by hopefully taking some cost out.
It's good to hear the bright side. I feel like we often talk about the difficulty of making the transition and moving to sort of an all-patient, all-payer model, but there certainly are some reasons why CMS is doing this, and so to hear you talk about them I think is helpful. I do want to finish up by asking, I always like to look a little bit forward now that we're at the beginning of a new year. What can our ACOs look forward to in working with Caravan this year in 2022?
Yeah, there's several things we're working on the technology front that I think will be exciting for our clients in 2022. So one of the first ones is like our velocity of data. So I think all of our clients know that we usually or historically we're only able to receive the CCLF claims monthly from CMS. We're working now to hopefully the end of January 2022 actually to productionalize the flow of what's called the Beneficiary Claims Data API or Application Programming Interface. The acronym for it all is called BCDA. BCDA allows us to receive weekly files from CMS, and we can get them in a hands-free fashion because we can actually just do a direct technology to technology integration from Caravan to CMS to pull down all that data for the ACOs. So that's great because that lets us take a lot of our data points that our clients like to track and accelerate the velocity of that claims data to weekly. In some cases, we know it's going to save 2, 3, 4 weeks off the claims lag time, which is traditionally about 90 days. So it doesn't eradicate the claims lag, which is required because practices obviously generate their services or they deliver their services. Sometimes they give it to a third-party administrator to support them with billing. It still has to go through CMS for adjudication. All of that still has to happen. But now we can get claims up to 4 weeks faster if they come in early in the month, and late in the month, it's less of an impact. So that's one, to increase data velocity. We're also going to be working to really support, particularly our pop health nurses, in some point of care tools that we're going to be working on. improving our patient work lists, giving them tactical work lists that they can actually mark and note as they move through work lists that are more static. And by static, I mean like a fixed patient list if they're going to work their top highest risk diabetic patients, so that they can mark those patients off as they go through and have that sense of accomplishment that they're clearing patients off the list as they work through. So those are some dynamic components. And then we're also on the analytic front working on things to help our clients better tailor the opportunities they have that are unique to them. So we've got some opportunity analysis reports that we'll be working with clients here in Q1 2022 to help them pick their clinical and operational priorities. Things like if they need to work on post-acute strategies, if they need to work more on disease-based programs like COPD or congestive heart failure, we'll identify the patient population that are impacted, where they're at a cost per patient or cost per episode, relative to benchmarks such as the rest of their ACO, and actually even a more intelligent fingerprinted benchmark that looks at communities like them and patients like their patient population, so they can make sure they're working on the right areas of opportunity where we know there's dollar opportunity if they can make improvements, and we know they've got a sufficient volume of patients and opportunity that if they invest, they can recoup some savings. So those are some of the highlights.
Sounds like there's a lot of exciting things to look forward to in 2022. That's always great news.
Yeah.
Well, Tom, that it's been a pleasure having you on Healthcare by the Numbers. Did you want to leave our audience with any final thoughts or comments?
I think my note would be, I know everybody's still struggling with COVID. I'm personally really excited that we've had the extensions on the telehealth waivers and the capability to support patients and remote visits. So I definitely encourage everybody, obviously, to focus there. And then just for our clients in particular to know that we'll be trying to stay ahead of and in pace with where these CMS changes are coming, such as the changes to the quality measure programs, to try to lessen the burden on our clients and make it as easy for them as we can, because we understand and appreciate how dedicated they are to servicing needs such as the current pop health emergency around COVID. So we'll do our best to stay ahead and in front of the regulatory train that's always, I guess, tough to keep up with and keep them happy and successful.
Sounds great. Tom, thank you so much for joining us today. For our
Thanks,
audience,
Louise.
If you would like to learn more about Tom Hawks and the work he does at Caravan, you can find him on LinkedIn at Tom Hawks, that's HAWKES, and at www.caravanhealth.com. I want to thank everyone for listening today. We are Caravan Health, and this has been Healthcare by the Numbers. Until next time, take care.